Thank you for that introduction. I don't have any relevant disclosures. So we know that different jobs have different stakes. I'll give you a classic example of this. So in 2010, my husband and I got married in the Washington, D.C. area. We had a lovely rehearsal dinner at a nice restaurant, and my sister-in-law somewhat reluctantly handed over the car keys to her brand new car to the valet driver, and this is what she got back at the end of the night. Now, unfortunately for that valet driver, that was both his first night and last night on the job, and that's a known complication of that job. And I think a lot of us can relate to that. We've all had that sinking feeling when we have an adverse event, something goes wrong, patient has a complication. We worry about that patient's physical and psychological well-being. We worry about what our peers will think of us. We're ashamed and embarrassed. And then we worry about what the consequences may be from the institution we work for. How supportive are they going to be? Are they going to try and blame an individual? Is it a systemic problem or a process problem? And this all really makes us vulnerable to what Dr. Albert Wu, he published a great paper in 2000, highly recommend you take a look at that. He termed the second victim syndrome. And this is when, as providers, we experience trauma as a result of an adverse or unexpected patient care event. And when you survey providers, up to 43% will say that they've been the second victim. And if you ask them within the last year, have you been a part of a clinical event that caused anxiety, depression, or concern about your ability to do your job? And 30% say yes. Now, an astounding 1 in 4 providers deals with the complication entirely alone. So that's 1 in 4 of your colleagues, medical students, residents, fellows, your fellow colleagues, staff members, nurses, APPs. And this really sets us up for a number of dysfunctional coping methods. Everyone knows the surgeon who gets angry when things don't go their way in the operating room, or who becomes defensive towards a patient after an adverse event. We blame the fact that they're a smoker, they're diabetic, they're obese, they didn't listen to the post-op instructions. We blame the healthcare team because it's always anesthesia's fault, right? So there's always somebody else to blame. Or some surgeons lose their nerve and get a paralyzing fear of when is the next complication going to happen and what will happen when that occurs. For some physicians, that leads to burnout. And for others, substance abuse. About 10 to 15% of physicians will develop a substance abuse problem during the course of their career. So I think we can all agree that while it's good to learn from your own mistakes, it's even better to learn from someone else's. And that's really the role we have as educators. And when we're teaching, I feel like somewhat like a parent with our residents and trainees. It's kind of like parenting, right? We want to prevent them from having a complication, save them some heartache. And I really want them to learn from my personal experiences. And to do this, I think we have to be concrete. So this is not the time to be cryptic. So I'll give you an example. When we're in the OR, we're doing an orthotapic reservoir placement. Rather than say, listen, this is one of the more critical parts of the case, there's a lot of things that can go wrong, I give them a concrete example. I tell them that my first year in practice, we placed an orthotapic reservoir. Case went great, but post-op day 1, patient developed a lower extremity DVT. We were quick to diagnose it, we got him anticoagulated, but we missed what was the actual cause of the DVT, which on imaging later, days to weeks later, found that he had compression of his external iliac vein. That was not something I'd ever seen during my training, but that's a concrete example to give the trainees, so hopefully it never happens to them, and it reminds me of the complications so it doesn't happen to me. Peer discussion, this is one of the methods I rely on personally. I've been in Toby's office many a time after a complication to have that discussion, whether it's in an informal or formal setting with your colleagues. Many of us in academics do this as a form of M&M, and I know the tone of M&M varies significantly from one institution to the other, but as educators, it's really our job to set the tone. Is it going to be an educational patient safety experience, or is it punitive? And the tough questions really should be directed to us as faculty members. We're ultimately the captains of the ship, not the resident or fellow that was involved in the case. And it's our job to point out what the actual teaching point of the M&M is. It's not about the timeline and who did what, when, but it's what is the take-home point? Why did this happen? How do we prevent it from happening again? Mental health counseling. So we know as physicians we're reluctant to engage in any kind of medical care, but especially mental health care. So when surveyed, 40% of providers say they're reluctant to seek care. And part of this is for fear of licensure problems. Many states have questions when you're applying for your license or applying for renewal as to whether you have sought care for a mental health condition or actively seeking care. And so in states where they do ask those types of questions, providers are 20% less likely to engage in mental health services. And that's often because as physicians, we're programmed to cope alone, and we have the survivor mentality and are worried that we'll be found out and that we have imposter syndrome and maybe we're not as good a surgeon as we thought. Now, the University of Utah published this study last year, which I thought was an excellent idea. So they offered their residents a one-time opt-out mental health appointment. More than half of residents chose to attend that appointment. 96% felt it was worth their time. 93% felt that it demonstrated that their program actually cared about their well-being. And 98% recommended that those appointments be offered to future residents. So anyone else who is in education and trains residents knows that to get over 90% of residents to agree on anything is like nothing short of a miracle. So I think this is a testament to like the power of opening up the dialogue and discussion and helping remove some of that stigma. This is something that we have at Mayo Clinic, and I'm sure many other institutions have something similar. It's called the Employee Assistance Program. It's no-cost, confidential counseling that's offered to employees and their qualified dependents, and it helps essentially connect employees, and it's not just for physicians, it's for any employee, but helps connect you with some of the community resources as it comes to addiction recovery, marital issues, grief counseling, mental health services, and parenting resources. So I'd encourage you to see what your institution or community has available. And if it doesn't have something available, I think this is something to bring to the attention of management. Oops, can I get next slide? Help program, also something that we have at Mayo Clinic. Many other institutions have something that goes by a different name, but this is a strictly confidential, one-on-one peer support group program. After you've been a part of some traumatic or stressful work-related event, they'll connect you with a fellow peer so that you can essentially have that debrief. And again, confidential, and it may not be somebody that you necessarily work with on a day-to-day basis, hopefully opening up the dialogue, making you feel comfortable to speak about it. The state of Minnesota, I believe the medical board has something very similar. So there may be some state medical boards that also offer something like that. So another potential resource in your community. Lastly, the AMA has a number of excellent toolkits online. Some of them are modules, and they're designed for individuals as well as organizations. These were some of the toolkits that I thought were pertinent to this talk. They have one on collective trauma, physician burnout, and how to respond compassionately after physician suicide. So in summary, recognize second victim syndrome. We need to be transparent with our trainees about some of the more challenging aspects of our job. Know your local and community resources available. Thank you very much.